I think we are live on Facebook, but YouTube is giving me some trouble. So, tuck my head back in.
Greetings, people.
Greetings, everybody. Welcome back to Dr. D's Discussions, Season 2.5. There's a reason why that there was a break, and we're actually going to go through the main topic today about why there was a break. So, let's do it up. So we're going to talk about mental health, disease, and illness today. I'm joined by Lebaron Agostini, as always, and then a special guest host, Rachel DeRIta.
Hello, thank you so much for having me.
So it's a GGCB Thomas Jefferson exclusive
Collaboration right here.
Yeah,
Shout out to the Genetics, Genomics, and Cancer Biology Department.
We have no affiliation in terms of opinion, and our disclaimer is that we are students, and none of our opinions reflect on
our mentors at Bloody Blavity. Just
yada, yada, yada.
check our website for the disclaimer. Call our lawyers if you got a problem.
Yeah, there's a reason why we have the LLC. So tonight we're going to have a little bit of fun. I know it's not fun to talk about a serious topic such as we are talking about, but to destigmatize the topic that we are talking about, let's have some fun with it. Let's keep it light. And let's really, kind of dig down into what is really the heart of, depression and anxiety. What are the methods to treat it? Whether that be pharmacological, whether that be, holistic approaches, whether that be mindfulness, meditation. It really doesn't matter how you treat the disease, as long as you get help. And that's a thing. And what we really want to promote tonight is that if you're having a problem, reach out and get help. If you're having very difficult times with anything, don't be afraid to actually bring it up to your boss. Don't be afraid to bring it up to somebody that's a little bit above you in terms of the hierarchy of where you're at, because you can only exacerbate the issue if you don't. So, given that fact, let's get into it. Let's see what we got. So. There is a graduate student mental health crisis that's considered in this country, and we'll give you some.
In multiple countries, I think it's.
Oh yes,
it's definitely a worldwide. I mean, in developed nations that have serious graduate. I mean, one of the most recent studies that assessed graduate school mental health for PhD students. I think it came out of like Switzerland or like Sweden or something like that. So I mean, it's definitely like an issue that affects people in PhD programs and graduate schools all over, but particularly here in the U.S., we have mental health issues here that we tend not to speak about,
and let's not limit it just to graduate students. There is a lot of just overlap between any type of field, like even if you're an accountant, or you're somebody that fixes potholes in the road, there is mental health in every single thing. So let's be honest about that. And it's just one of those taboo subjects that even my dad talking with me has had difficulty being like, hey, when I was in your age group, I had the same thing. So it's kind of like one of those issues where you don't want to talk about it because you're ashamed or you feel like somebody else is going to stigmatize you about. But let's normalize that.
Yeah, you're not the only one. It's the kid in class that's afraid to ask a question, but the one kid that asks it, everybody else is relieved because they were thinking the same thing and they wanted that question to be asked.
Yeah.
So hopefully this can sort of be a ripple effect as well. It also doesn't make you any less intelligent or
weak or anything like
that.
I mean, I think the most important aspect about doing the show with this topic is that people should feel more comfortable facing these issues and talking about these issues.
Yeah, I would say that's the number one goal.
It's not selective for anyone in particular. Everybody has, problems dealing with things. And specifically, if you're waking up out of bed and you're feeling depressed on a consistent basis, or you're having anxiety that you feel that you can't overcome alone, it's the next best thing to do is try to get professional help or talk to somebody about it, and maybe counseling and, going to a physician is the next best thing. But I don't think that people should try to, feel ashamed or down themselves about maybe having an issue when it comes to like mental health issues in this regard.
And I really believe that, being an American, not speaking for Europe or Sweden or Switzerland.
America.
We have this bootstraps type mentality where, you don't want to like show any type of weakness because it's a perceived thing that, you may not be able to, handle whatever job that you're trying to get or any other type of thing. We have that really individualistic, you have to do it on your own type of mentality, and it just isn't right. It's not true. Like, we all work in collaborative teams. So, but pointing at attended counseling for mental health concerns, 2013 alone, 50% of graduate students taking a medication for mental health concerns. 33. So, out of the three of us, I know that I take a medication for mental health concerns.
I have sought professional counseling.
And I know that Lee's just a stubborn son of a bitch.
I just drink my problems away. Don't mind me.
Yeah, but the same thing is, like, purposely injured yourself. No, I don't think we've run into that or considered suicide or anything else. But, that top one, looking for counseling. I know that I'm in cognitive behavioral therapy sessions, and I work with a psychiatrist and different things like that. So, it's one of those, it's pretty prominent, 1 out of 2.
Yeah, I mean, especially
Basically,
amongst the high stress, high pressure environment of graduate schools. I mean, it's it's happening actually for med schools too. There's statistics associated with MD students and rates of suicide or rates of depression, anxiety.
In New York recently, there were 2.
Yeah, 2 at NYU actually. I mean,
so I would like to
support goes out to those people there.
Yeah, I would like to. I mean, specifically for that, and then everything else that has happened before. Really, my heart is with all of you.
But there's a common theme here where people of our age group, young adults, mid-20s, are put in severely stressful situations, and people have trouble coping with these things. And we look at these rates and these statistics about suicide attempts and anxiety and depression, but we're still afraid to talk about these issues. And I know universities try to do a better job at having access or providing access to counselors and things of that sort, but there's still a stigma associated with this that has a societal origin, and we as a society need to overcome that and make it okay for people to talk about their mental health issues.
I just wanted to sorry,
I like that you brought it up, is that right behind us, I brought up the student personal counselor.
Of course, yeah, Jefferson, this is here, and I wanted to make another comment too, stigma wise, just as a female. The idea, I've definitely felt at times the notion that, like, I shouldn't show as much emotion as I'm feeling because women are the emotional ones, and then that equals weakness, and that's why we can't hold higher positions and all that BS that we want to keep moving past. And so I feel like for me that in the past that has added a bit of a layer that I've wanted to.
It's extra stigma that's associated with
an extra thing to say. Well, and now she's.
Yeah, I mean, it works in both ways, because for women it's like, oh, I don't want to be too emotional, and for men it's like,
oh, she's
I'm hyper masculine. I can't be emotional. Like, I'm supposed to bite into this wild chicken and get over my problems or something like that. I'm not sure if that's what masculine people do.
Well, I mean, there's definitely toxic masculinity as well.
And what is it? Emma Watson had, we had this discussion 2 weeks ago when we were talking about the show. Is Emma Watson really said that we got to get rid of the masculine stereotypes and the feminine stereotypes.
Right. Yeah. The Anne Hathaway also said you have to free in order for women to be completely free.
Hermione,
Shout out to Emma Watson, by the way.
Right.
You're
love you.
The super feminist, and I love you.
Then there was another celebrity, Anne Hathaway, that had a sort of a feminist agenda as well, and it had a quote of hers was in order for women to be completely free, men also have to be free from whatever the stigmas they have to basically be who we are regardless of gender roles. Be who you are and be your unique strengths, and that's what you can give to the world regardless.
So on top of this, I just want to let it be known that we will put this up on Bio's Life Media as a PDF format so that you can actually check out if you are at Jefferson, because I know that we are all at Jefferson, so most of our connections through this video will go through Jefferson. And we'll also offer links to the NIH, the National Mental Health Institutes as well. Check them out. They do have good resources.
Yeah, at the end, I'm going to have a couple more things that I'd like to plug because I've really explored, I've really gone deep, to really try and empower myself with not just getting past my acute problems, but really setting myself up for, sustained resilience, I would say.
Also, if you're at a major university, I mean, do. I mean, if you're at a state university that's large size, there's definitely mental health resources on campus. They may not be as publicized, but they're there. So if you are feeling these types of things, reach out to professors, reach out to counselors on campus, and they'll try to guide you and put you in the right place so you can find, the right type of help for you.
Yeah, like one of the things that, before we move on to the types of depression, for the University of California, Berkeley, 43 to 46% of graduate students in biosciences were depressed. And 2015 University of Arizona Graduate Student Mental Health National Association found that a majority of doctoral students reported more than average current stress or tremendous stress, and endorsed school and educated related issues as the most significant contributors to their stress.
Yeah.
So it's not like you're alone, and that's really what we want to drive home.
True. And science is hard as shit. And more importantly,
it's failing.
Dealing with failure
Yeah.
is, it's a trying to think. It's something you try to cope with, and it's inherently stressful. And for these unique subset of humans in this country and in other countries that are in this field and dealing with these types of challenges, a lot of these students are faced with dealing with stress and pressure because it's so hard. And biomedical science was the example of the statistics that we use, but I mean, just PhD programs broadly, engineering, philosophy, whatever the case may be, there's this pressure for you to be productive, and that's hard for people to deal with.
So Rosa had a question. Love you, Rosa. So she's like, what happens to students and or people in general that can't afford a copay or do not have insurance to afford assignments or appointments?
So a lot of campus stuff
Jefferson
is paid for.
Your first 3 sessions are paid for.
Right.
And then past that, even if you don't have insurance or if you have student insurance, it's $20.
Yeah,
Yeah.
So at Jefferson, it's good.
Right.
I don't know. I can't speak for anything outside of that.
Yeah.
Generally speaking, PhD students usually have student health insurance associated with their
Right.
stipend or part of their university. If
Hopefully
you
that's
access
the case.
mental health services on your campus, I don't want to say that they're 100% paid for, but I mean, the likelihood that mental health access on campus is usually compensated in some way through the university. At least, especially if you're trying to get first sessions or walking to a clinic for the first time, a lot of the times those things are covered.
All right.
Yeah.
So let's move on a little bit. I hate to cut off anybody's
Mojo.
mojos or flow. We're going to talk about clinical manifestations or types of depression. Major depressive disorder or major depression. It's associated with weight gain, weight loss, trouble falling asleep, feeling restless, agitated, being tired and without energy, feeling worthless or guilty, trouble concentrating or making decisions, thoughts of suicide. Persistent depressive disorder is, I doubled that on the slide, so there you go. It's manifestations
Because it's
of
persistent. That's why you did that.
So it's 2 years or more where you have these types of symptoms, and it literally changes your entire perspective and outlook on life, where you don't find enjoyment in the things that you used to. Like, I know Lee likes basketball and biology.
Pretty good. Just throwing it out there. I'm short, but I'm good.
Yeah.
Don't let height.
His endurance sucks, but don't let him tell you anything else. But it's just where you lose desire to do things, and it's become completely normal. There's bipolar disorder, something that runs in my genetic line, where you have stages of height of happiness and what's called your manic phase, and then your depressive state, where just like major depressive disorder, you can't do anything.
Yeah, can't get out of bed.
Literally just sit in bed all day.
Yeah, it's a roller coaster.
Seasonal affective disorder. Have you ever gotten sad when it's like November, December,
Right.
the sun goes down earlier?
Yeah.
Psychotic depression, which is more associated with hallucinations, a little bit with schizophrenia, but it really does have a little bit more of the depth of symptom that you wouldn't see in just like somebody who's sad or like major depressive disorder.
I think the psychotic depression thing is probably what people would be generally most familiar with. I mean, you hear voices, hallucinations, like the crazy person that you think of. That usually is the type of category that these types of things fall into, as far as like just a public perspective of it.
That may have also the heaviest stigma to it as well. So don't ever be, when you are in that safe space with either the professional or a trusted one or a loved one, really, really just speak up and be truthful, because
Sure.
everything is able to be talked about and addressed in some way. So definitely,
So
still with the theme of speaking
yeah,
up,
exactly.
basically.
There's a lot of, and that's the thing. Like the most severe mental health issues, I believe, are the ones that people are acutely aware of, such as from like Law and Order SVUs.
Well, yeah, I was about to say media depiction in
It's
general.
one of
Yeah.
those like there are
that's the whole
shows
thing.
that really like, wow, you see a schizophrenic that kills somebody, or you see
Right.
somebody that does
Yeah.
this, or somebody that's psychotically depressed.
Right.
But that's not the majority.
Yeah, that's
No.
not what that disease state manifests as. I mean, even when let's take PTSD for an example as well. Like when
Right.
people think of shell shock or PTSD, you think of the crazy veteran going and doing
Yeah.
something that's outrageous. And PTSD is a person that walks into a mall and starts sweating because they're
Right.
around 200 people.
Right.
Yeah.
Or
Like
or
these are the
the,
same conditions, and
Yeah.
that same person with PTSD and that manifestation still has the same fears of coming out and speaking about it because of how people generally view these mental health diseases.
Yeah, you never know where they're coming from, basically. So
And
always
even
be able
with
to speak up.
when we get into anxiety, socialized anxiety disorder, people have the same manifestations of symptoms. So there's a lot of degree of overlap that occurs between a lot of mental health issues. Like you can have people that have depression, have PTSD, have anxiety,
Yeah.
and they all overlap with one another. And a lot of the drugs that actually are prescribed that may not have the efficacy that we'd like them to have, but there's the Human Brain Project that Obama signed into law when he did the cancer boost,
Mhm.
a couple years ago in 2000, I believe 16 or 15, when Joe
Yeah.
Biden was, he tragically passed away from brain cancer, where they increased Alzheimer's research, brain research, cancer research, and the like.
I just want to touch on that just a little bit as far as the meds and the expectation that she said, like for people when they take drugs, and like the brain stuff is complex as hell. I mean, all science is hard, but neuroscience and depression and these things, a lot of the times, we really don't know what the hell's going on.
You can't cut somebody open.
Yeah, it's not,
You just can't cut somebody's brain open. You can't start sticking probes into somebody's brain because.
And that lack of understanding that we have when it comes to how brain physiology works in regards to these disorders is why they're so hard to treat. There's a lot of overlap with how these drugs work. Just as you said, there's a lot of overlap with these disease states. Somebody could have PTSD and also depression and what have you. And that's because some of the same mechanisms that cause one disease also manifest these other diseases in ways that we don't fully understand. And clinicians and researchers are trying to do their best to try to figure that out.
It's kind of like Alzheimer's, where you don't know if the amyloid plaques are the cause of the disease or a product of
Right,
we just had 2 phase 3 trials fail for Alzheimer's. We have no idea how to treat this disease.
Yeah, very complex. And it's that's one of the reasons why I when I was going through my experience with stress, depression, anxiety, I was also very interested in the behavioral and lifestyle type things like meditation, because it was very result based too, because again, a lot of the biochemical stuff that we're still figuring out, it can be good when it works, but it also, for me personally, it was also empowering, because there's still a lot that we don't know, and it's okay to find something that works for you, and when it does, definitely
stick with it.
Still keep it in your
because everybody's different. These diseases.
As scientists, we always want to try to explain it, but it's also okay in these instances when you found something that works, and then me as a scientist, I get more inspired to figure out maybe why is it working. But even if you're not, that's also okay.
So I have a comment here. I'm actually going live on my Instagram, and one of my followers says, but in science, everybody views all of them as weaknesses. And it's like I said, it's kind of like the social stigma where it's like, well, if you can't cope with this high stress environment, somehow you're failing at doing this thing, and that's the stigma, and that's not the case. I mean, everybody's human, and everybody deals with these types of pressures in different ways. And having this conversation, the reason why we're filming this, the reason why we're putting this out there on the internet is so that people that are feeling like this, you don't have to feel like you have a weakness, go and talk to somebody, go and find help, go and talk to your PI.
Yeah.
You know, there are people that are close to you that want to help and resolve these issues with you.
And stemming off that, I just want to, like, I have a slide behind us. Almost 11% of people between 18 and 25 and 7.4% of people between 26 and 49 have had a major depressive episode within the past year. That's 1 out of 10 people. Like, you know 10 people.
All professions.
Right.
Yeah.
All, yeah.
Anybody.
Right.
In America, you know what I mean? Like, females tend to have it 2 times as much as males, but that's because it's underreported in males.
I would say, that
Right.
females might be more willing to talk about
I think
it
it's the
because-
estrogen. No, I'm playing. I'm just.
Yeah.
Well, the next one. Yeah, let me talk about PMDD, premenstrual dysphoric disorder. I think I should be the one to listen.
Well, actually, it's postpartum,
Yeah.
dysphoric disorder, situational depression, atypical depression. There are all other ones that
Right.
we didn't really touch on, but they're at such a lower percentage of the population compared to
Right.
your major depressive
Right.
disorders
Well,
and
and,
bipolar and stuff like that. But what is it? Even without severe impairment or severe impairment with a depressive episode, 2/3 people that suffer from
Right.
depression have a severe impairment where they need to take off from work for a week, or they need to take off for this. They need to actually go to a medical professional to actually get help or get the treatment that they need.
Also, if you guys are watching this video and there's a depression or anxiety disorder that we didn't touch on in
Right.
complete detail, or that you know of and you want to learn more about, please comment or shoot us an email or DM or something like that, and we'll try our best to provide resources and information
Yeah.
about that disease state.
It's such a vast topic that we wanted to talk about mental health, illness, and disorder, but we can only talk about 2 things: anxiety and depression, because of how large it is.
Yeah.
Like, we can't talk about schizophrenia. We can't talk about even bipolar disorder in such a way that I know it's related, but
I mean, there's
you
definitely.
can do a show about each and individual one of these subtopics. Like, it's insane that there's just so much information, but lack of information on each individual one.
Yeah, there's definitely lack of knowledge as far as the complete and full understanding. I mean, mental health is not to undermine other diseases or anything like that. I don't want to get my cardiologist, up in a fit, but like mental, schizophrenia isn't hypertension. There's defined mechanisms for why blood pressure is. And yes, we do know how these receptors function, but the same molecule in the same dose isn't for the same patient. And sometimes stuff doesn't work.
Right, it's very complex.
Yeah,
that's. I mean, I was mentioning this before we had started recording. I think with Dave that when I look at studies that involve psychology and behavioral science, like I look at it with a slightly different lens than I would when I'm reading like a cell biology paper about cell migration that can be measured. And it's not to say that I still don't have the same rigor when I look at it scientifically. I'm just saying that it's a different, I'll use a different lens, so to speak, because of how different the topic is.
There aren't set parameters upon which you can observe that actually give you an output.
Right, yeah.
And even if the
there
output
are
that you
parameters.
get, there's so many variables with that
Yeah.
that it doesn't necessarily, I don't know. I guess I'm mansplaining.
Oh, stop it.
But yeah, you're absolutely right. Like, there's so many variables when it comes to this type of research that you can't necessarily look at it like, oh, I put a mutated P53, protein inside this
I mean,
cell.
it's
and
this
then
is
it got
the outcome.
cancer.
Right.
Right.
Yeah. It's not as cut and dry. I mean, don't get us wrong. I mean, I don't want to create a narrative here that's like, hey, mental health, there's nothing we could do about it. People do study this in depth, but dealing with it as far as solving it as a problem is not as easy as other diseases, and that's part of the complexity.
Right.
Look at behind us. There's how many different SSRIs that are approved by the FDA, but look, one's for depression, one's for depression generalized anxiety, one's for OCD, panic disorder, bulimia, OCD, depression, and they have overlap. And it just goes back to the thing that these things are all related.
Yeah.
They literally are. And
I do want to say in brief that tricyclic antidepressants and SSRIs, which we're going to get into these mechanisms later and what these words mean. Oh, boom, right behind us.
Here we go.
Selective Serotonin Reuptake Inhibitors. They are effective in treating depression in patients against placebo, which is sugar pill. The reason why we prescribe these things is because for the majority, at least for statistical significance, compared to giving you nothing at all, these drugs do help treat depression disorder.
Mhm.
So
However, the thing about it is, and I'm going to be very real, I'm going to skip ahead to it. I'm going to talk about the mechanism real quick. SSRI, it's a selective serotonin reuptake inhibitor. So basically what that means is you have a presynaptic cell that spits out a whole bunch of neurotransmitters at the next synaptic cell, postsynaptic cell, and that's how your brain communicates with itself, and your body and your nervous system communicates. But basically what it does is, what the drug's supposed to do is keep a whole bunch of serotonin in that synaptic cleft so that it makes you feel better. It's kind of like cocaine.
Serotonin!
So I don't want to say it's.
it literally.
You guys, I was at this party the other night. We did
was-
some lines of serotonin.
Oh
it
my
was
god!
great.
Yeah.
You know what?
It
I brought out the
was
Lexapro, and we just did so much Lexapro, guys.
Let me just
No, but
I just took straight serotonin, man.
Yeah.
I just like, it's like
give me some
escitalopram is
tryptophan.
actually that's the isomer for Lexapro. Let's just say this: serotonin as a neurotransmitter, it's a molecule that's produced by the presynaptic neuron, as Dave said. Serotonin is the neurotransmitter that's generally associated with feelings of happiness and well-being. So
and dopamine.
and dopamine
Right.
as well. A lot of these drugs also work
And
on
then
dopamine.
there's
that why they call it
norepinephrine
And
or
norepinephrine.
noradrenaline reuptake inhibitors. There's MAOIs, which are
Monoamine oxidase inhibitors. I mean, that actually helps with the degradation of dopamine and stuff like that. But ultimately, these drugs, however they work, are meant to increase the levels of these neurotransmitters that are associated with good feeling. The way that these SSRIs work is that if you're in a hallway in between two doors, the door on the left opens up the door and spits somebody out. Now, while it's in the hallway, it can do two things. It can go back to the door it came through, or it can walk through the door that's adjacent to it, or across from it. So what these drugs do is that they stop that person from walking into the door that they came from. So the only thing that they can do is go through the next door. And so in science speak, we increase the synaptic concentration of these neurotransmitters so that you get postsynaptic response, and that's supposed to make you not kill yourself. And most of the time that works.
But there is, and we have to be very adamant about this. And I know that it's always with certain things. We're not MDs, we're not psychiatrists, we're PhD students. But we need to be very honest about the black box warning that are on SSRIs and SNRIs and MAO inhibitors.
And by black box, we mean something that's actually associated with FDA regulations, meaning that, hey, there's something that you should know about this drug just in case.
And what it is that it actually may worsen your symptoms. It could actually make you have thoughts of suicide. It could make you want to actually,
especially in
not go out
teens.
public. Teens,
right, and
adolescents,
and young people. That's where I end up really feeling,
So I don't want to scare you away from it.
Right.
But the science is behind.
The reason is, why is that? Why does that occur? And it's because your brain is really fucking complex, and because of that, there are these. It's really freaking complex, and because of that,
it's freaking complex, guys.
These things aren't as easy to to solve as other problems.
But I did want to point out this meta-analysis, and it had about 3,000 different people. I want to say 3,700 people. The only time that an SSRI or an SNRI wasn't better than placebo in this entire study was for PTSD.
And that's because it's trauma-induced.
Yeah.
I think that's the reason why it doesn't work, because it's trauma-induced.
It works better in anxiety disorders than depressive disorders. However, you got to take it with a grain of salt. And like we've said, like I've said, is that there isn't necessarily the best efficacy compared to, say, something that kills, like an antibiotic. It works 90%.
Right, compared to other drugs, yeah.
An SSRI or an SNRI, it may take you 3 or 4 different times to find the correct one that works for your biochemistry or for your biology.
Also, these drugs take time to work.
Exactly. So I'm actually going through what's called a titration, where you're increasing the dose from 5 milligrams, 10 milligrams, 20 milligrams, so on and so forth, so that I don't have an adverse reaction. But it takes time, and then eventually you feel recovery.
Yeah.
And it's not necessarily that these drugs are the end-all, be-all, where you're going to feel, oh, wow, I just took some ibuprofen, my headache went away, or Excedrin, my hangover's gone, you know what I mean? It's one of those, you have to do other things on top of that. And I know Rachel's going to discuss some other things, but I want to touch on another thing that I'm doing is cognitive behavioral therapy, where, it's used to manage the symptoms that you have, or what I have is that, well, let's just go through this little cycle situation. What triggers a problem? You criticize at work. Thoughts. I'm not good enough. And then you go through emotions. How do I feel? Worthless, anxious. Avoid contact with others is behavior that could happen, such as missing work, missing class.
Right.
Physical reactions, feeling tired, loss of appetite. There's times where I've lost 10 pounds, 15 pounds in 2 weeks because I haven't eaten or anything.
I went through that as
Dave,
well.
what diet are you on? I'm on that depressed diet.
Yeah, I would
That
offer you
anxiety, depression.
So, the steps in CBT, you identify troubling situations or conditions in your life, become aware of your thoughts and emotions and beliefs about the problem, identify negative or inaccurate thinking, and then you reshape it.
Yeah.
So it sucks horribly.
It takes effort, and that's
But-
also speaking from experience.
But it takes time. And,
Yeah.
I have to I have a diary now. I have a journal.
Yeah.
And I
do I.
literally write down when I have an episode, what's the cause of it, try to discover the root thought process behind it, and then present it to my therapist.
Yeah,
That's literally how it goes.
a little bit related
It's
to
kind of like an
mindfulness, too, which we're
interpersonal
gonna get
question,
to
but like,
later.
how have you felt, just like being like in this position as a grad student, we're here at this university, super high stress. How have you felt like since you've come to the thing, like, okay, obviously there's something fucking going on here, and I need to get some help. How have you like since that decision and then where you are now? How's that experience been? Finding help?
Sucks.
Yeah,
It's horrible.
Good about it.
It's good. It's not gonna be fun, but at the same time, I feel a lot better than sleeping on the couch for 5 days in a row. I actually feel better than not feeling like a piece of shit. Excuse my French. I know I told you to watch your language, but
we curse here. Sorry, it's
Yeah.
explicit PG-13,
I mean,
blibby blobby.
It's gonna sound cliche, but I mean, like with the cognitive behavioral therapy, kind of like, I mean, it is also simple though. Change your thoughts and change your experience, and that doesn't, even though it's a simple concept, it doesn't mean that I'm saying that it's easy. And again, I'm speaking also from my experience too, of like really, instead of wallowing in something and just saying this sucks and that's just the way it is, really challenging myself almost in a scientific way too, of like, but how true is that that this is just the way it is? How true is that? And then you can find out that that's not necessarily true, and your mind is just being a little devil. And that's what cognitive behavioral therapy, I feel like, can really strengthen, is you all challenging your own thoughts and choosing the ones that are true and will serve you versus not. That's what I feel like this kind of
base
analysis
yourself
can
in
do.
reality rather than in reality that your mind comes up with a conceptual.
Yeah.
Also, I think just as graduate students in this field, I think that like, we try to solve these problems a lot on our own. It's almost the nature of our personalities.
Right.
We're independent, we're self-driving, and I think it's important for us to realize, like, when we're faced with these types of issues, seeking help from friends and family or professionals is like the first and the best thing that you could do for yourself.
I'm gonna say it again. Speak up.
All right, Rachel, I want you to take over.
Yeah.
It's your half of the discussion
Yeah.
now.
So still not an expert in this yet, but this is something that has recently sort of come into my life. My mother is also a coach in this technique. So first,
Hey, shout out to Rachel's mom real quick.
So the parasympathetic nervous system. Actually, I should probably go to the next slide first. That would probably be better. So we have the 12 cranial nerves that are kind of the epicenter for the rest of the nervous system, central. And so the vagus nerve is a central part of the parasympathetic nervous system, which is responsible. I'm going to focus on the heart because that is what is related to the next thing that I'm going to talk about. That it's responsible for what is called not just your heart rate, but therefore heart rate variability. And what heart rate variability is
Did I go forward to that? Or?
What did I do? There we go. So heart rate variability. So basically, our heart isn't just a metronome. That when it has, there's actually between each beat, the time that elapses will vary. And you're supposed to have a healthy type of variation for that. And that's a readout of your vagal tone and the way that your parasympathetic nervous system, which is responsible for the sort of deactivation versus the sympathetic, which is excitatory. So if we're talking about dealing with stress and anxiety, having increased vagal tone, which is read out through heart rate variability, and there's some exercises that you can do. So the before this, so like the reason why, I don't even know where to point this anymore.
Oh, do you just tell me to go?
Yeah,
There we go.
go back.
Oh.
I think to a list. Yeah.
There we go.
So the reason why the vagus nerve is important, though. So before I get to like the exercise you can do, the more clinical stuff involving the vagus nerve, that the FDA, I think it was around 2005, they approved vagus nerve stimulation for the treatment or improvement of disorders such as migraines, mood regulation, in epilepsy patients, but then also anxiety. And so these are just some titles of the studies that I found. There are a ton. These are just some of the ones I picked out.
The only
So,
reason
yeah.
I'm going to jump in here is
Yeah.
that I know that vagal nerve stimulation usually involves surgery. Am I incorrect in that?
So the actual technique for it, I'm not familiar with, and it is actually it is invasive, expensive, and complex, and so that's kind of why I'm gonna talk about the what it's called heart math, and that's actually a way, because there are other ways to naturally stimulate your vagal tone.
So
and
just to
change your
segue
heart.
from both
Yeah.
of you guys' topics, the FDA cleared the handheld non-invasive vagus nerve stimulator
Right, the electrical.
from Electrocore LLC for the treatment of migraine patients in adults. That happened in April 2017. So
Yeah,
this
that was
device will
nice.
likely probably seek further approvals for other
Right.
types of diseases associated with
I know,
vagus nerve
Yeah, I
stimulation.
think like early on it was probably like a lot more invasive, but yeah, it's definitely become, because it's we're an electrical system, so now
There's also
handheld device.
something called Neurostar that's out there that's been approved since
Okay.
2008. It's electromagnetism. So instead of actual electrical current, it uses MRI.
Yeah. Well, I mean,
Technology to reset.
we have our
electrical
own, like our heart has its own electromagnetic field that can be measured. So, and your heart is actually also, like, your brain's not only sending messages to your heart, but your heart's also sending electrical signals to your brain as well. So that's the relationship between all of this. So
Yeah, shout out to the SA note in my heart for keeping me alive. I just appreciate you. You keep doing your job, and thanks.
I love you, SA Node.
So I did jump ahead to self-regulation and
Right.
education of vagal tone.
So basically, when just simple relaxation isn't enough, basically. So what is coherence? So coherence is basically the optimal synchronization between the heart and the brain, and then this can be read out by optimal heart rate variability. So there are some publications here that it's been studied. There's also, I have a link to what's called the Heart Math Institute that's heavily studying this, and there are over like 300 publications in
Can I
their
jump
library.
over to the heart rate, the coherence state?
Yeah.
So
Mhm.
you can give me. So describe to me what's going on here. What am I actually looking at?
Yeah,
So-
I have no idea.
Because I am not a cardiologist. I'm not
Neither
Rose's
am I.
mom or dad or anything. Like
Yeah.
I can't read any of this, but
Um,
obviously if it goes up or down, I know that. But
Right. So basically, it's not heart rate, but it's the heart rate variability. So when you see this, so this time is basically where somebody had done. So it's a very simple. I say exercise, but it's very simple. When they enter what's called coherence, their heart rate variability here is very erratic, or at times sustained, where it's actually not changing. So you would basically be maintaining the same heartbeat for an extended period of time, but that's indicative of low vagal tone, because the vagus nerve is supposed to be continually regulating this. So when you are in coherence, when there is proper communication electrically between your heart and your brain, you're going to see a smoother sine wave for your heart rate variability, that you're going to see a more healthy variation between each beat, because studies have shown, again, that our heart isn't just a metronome, it's actually responding. And that's also going to see other changes in respiration, and then the blood pressure. That's also, because if your heart rate variability is being properly regulated, then the blood pressure is also going to be properly regulated as
So
well.
basically what you're telling me is I have this, but I need
What
this.
we want- Yeah, and so there is so it's not the only place that is studying this, but the Heart Math Institute actually has I have it on me all the time. There's just a very simple, it's an app on your phone and a thing you can attach to your ear,
Oh,
and it
yeah, it
actually
is.
measures your heart rate. Yeah. And I've also, again, because I'm a scientist, I've experimented. I just had a really, stressful conversation with my boss or a coworker, or I'm just maybe there's no reason at all. I'm just having a bad day. I'll look at it, and you can sort of see when you're coherent versus not. And so the exercise is basically combining a steady. So generally they say 5 seconds in, 5 seconds out for the heart, for the breath. And then when you say heart centered, it's just sort of focusing in the chest area. And then with a positive emotion, but let's say, it's a really crappy day and you can't just manifest positive emotion. Sometimes also just the thought can happen. Sometimes all I have to pull on are my cats. Sometimes it's just been a bad day. But anything that can sort of harbor that emotion, because that, like our thoughts, and it makes sense because it is an electrical signal. That is basically the exercise to then sort of control your own coherence.
Hey, shout out to my girlfriend for my positive emotions lately.
Yeah.
I just
Where's it too?
so just I don't know. I actually just learned as this lecture you just gave about this. Would you say that? I mean, for people that are actually on pharmacological treatments, this is type of a technique that you could use in adjunction with.
Yeah. It doesn't matter what else you're doing. Even using cognitive behavioral therapy, you can look and again see what different states you're in with this thought versus this new thought. And sometimes it still won't change, right? Sometimes I've also had other challenges where again my ego steps in and I'm like, why am I still in the red? I just had a good thought, or whatever. But I know that when I do have a coherent state and I've sustained it for at least a couple of minutes, your cognitive function is also improved.
Yeah.
And there are studies for that. And then I've also experienced that myself, because then in the anxiety and depressive roller coaster, your cognitive function just definitely tanks. Brain fog. And we're supposed to be smart people as PhD students. So so I've definitely felt and it doesn't necessarily mean that I'm, super relaxed, or that when I'm finished, I'm not going to feel that anymore. I just feel more resilient. And I think there's a term for in the biofeedback sort of bioresilience to the thoughts and sort of being able to be more mindful.
It's a means to actually control the racing craziness that can happen and occur.
Right. Yeah. There were
when
some.
I'm going through CBT with my therapist, and I've only done one session of CBT. I did it when I was younger as a child, but as an adult, it really makes you she actually looked at me and said, "You just told me your entire history, and your breath is up here. Take a minute, breathe, think about something that you really enjoyed," and it really is.
Yeah, that's
exactly
that's
what you just said.
That's this. Yeah.
You close your eyes. She goes, "I don't care if it takes 20 minutes.
Yeah.
When you're ready, we'll talk again."
Yeah.
And she's actually gone, no. Close your eyes and redo it. And reset yourself.
Yeah, it really does. And so this is just a way to also read it out, because again, we're scientists. We like to be able to see numbers, and a lot of things in this field are very hard to measure parameters. So that's why this is a nice, nice thing to do.
It's pretty much a biomarker for the output of this technique.
Right. I don't want to rush us, but we're getting to the 45
Well, that
mark,
so that basically brings us to mindfulness, which is related to that. So Jefferson has it's called the Murrah Brain Center for Integrative Medicine, and it teaches mindfulness. It actually has programs for it, and it's also collaborating with the Yoga Research Society. So mindfulness is the process of basically being present and aware. Sometimes I like to use the analogy of being a third-person observer of everything. So you have a bad emotion, instead of internalizing it, just observe it and say, yeah, okay, that's that. You can not be it or identify with it. So that's my personal addition.
I don't know
to
if
this
you're
definition.
a Star Trek fan, but I like to think of it as
I am.
Spock-based metacognition.
Yeah.
You remove all your emotion about what you're actually observing your brain going through, to the point where, Jim, you're going nuts, or Bones, you're going nuts.
Yeah.
And I don't know. If
I have no idea.
I know
what's going on here.
But it's
Spidey sense? I don't know what's. But I get the premise
that's not the right
of
symbol.
this
Is that
type.
right? Yeah, that's right.
And did you know that's actually based upon a Jewish symbol? Of
Really?
peace. And welcome.
Okay.
That's
There
interesting.
we go.
It's
Yeah.
fun.
I mean, I
Gene
think
Roddenberry is Jewish.
I didn't
So
know that.
just
but
there you go.
fair enough. I think I generally
yeah.
get
So
the
we
premise
can,
of this stuff.
get into
So
some yoga.
I would not be able to talk about mental health, especially in my experience, without talking about yoga. I'm like in my lab. I'm just like everybody knows I'm a yoga nut. And so it also basically helps the practice of yoga, especially physically, when meditation, just sitting there in silence. Like there's some ancient texts that refer to the mind as a hurricane, and I totally, agree with that. So, combining it with breathing and physical exercise is also extremely healthy. There are hundreds and hundreds of studies on this. So that's why, you can eat, all you have to do is PubMed yoga. And of course the journals will be of varying merit or whatever. But to basically seek these benefits for yourself, a Jefferson specific plug, a block away from our campus is the Yoga Garden. I feel like that's one of the first places I started to go to sort of supplement my journey, because when I first started noticing that I just wasn't myself fully anymore. And then also there was another studio, Palo Santo Wellness Boutique, who they also do a lot of meditation workshops and different styles of meditation too, because just like everything else, one size doesn't fit all, and so certain things will work more for some people than others. So I really just have to give a shout out to them, and also a link to that. And then for more information on actual yoga research, because even though yoga is such an ancient practice, we're now finally using modern science to like prove the things that have worked, and now seeing why they work.
Yeah,
we're actually starting to crack it open a little bit, and some of the things were like, well, yeah, even though it was thousands of years ago, they were doing this for a reason.
Right. I mean, just to add to some of the validity.
Oh, I've seen that one. The one that you just brought up.
This meta-analysis.
I've seen I've seen that
associated with looking at randomized control studies for people with depression doing yoga. And if you guys want more resources or specific studies that kind of show the trend is, we'll post some of them.
Yeah, I've come across so many. I just sort of like log them away too. So
what we are going to do is we're going to do some follow-up. I'm going to do a more pharmacological perspective on my write-up, because that's and CBT, because that's my experience. I know that you're going to do more of the alternative, the yoga-based,
right?
A whole bunch of resources up at us.
Yeah, the yoga. One thing, the Yoga Research Society, which is probably one of the only ones of its type in this country, works closely with Jefferson. So if you guys want more information on that, that's definitely going to be.
If they have social media, please tag them, and we share stuff.
Yeah,
on Facebook
yeah, for sure. They actually
Instagram, have Twitter if they have.
Like
anything.
Twice a year they have seminars or they have conferences on Jefferson's campus.
Perfect. Cool. So we'll share all that information. We're going to have some follow-ups. So if you have any questions, please feel free to reach out to us. Start a discussion here on the Facebook page. We're going to share it on YouTube. I couldn't get the dual live feed going.
Streaming thing, technical difficulties.
I'm still working on it. I kind of am terrible at technology. So there's that. But, I just wanted to thank, here's some extra resources. This is from the National Institute of Mental Health, .gov. Check them out. They'll direct you to, studies, any type of medication, anything that you need that we haven't covered. And then, there's an extra slide about Lamotrigine and MAOI inhibitors. But, I just want to thank Rachel for being a great guest host. Lee, do you have any?
Just some closing remarks. As you already know, follow me on Instagram at Leave the Scientist. If you guys are taking specific pharmacological agents and you and your physician, you don't really understand how these drugs work, so you read the package insert and you're like, this is a bunch of mumbo jumbo, I'm still like having issues understanding what's going on, please reach out to me. Drug stuff is kind of like what I do. I can't tell you how to take your med or what to prescribe, but if you want to know the mechanism of action, if there's published research on it and data associated with it, I'll be more than happy to talk to you about how these drugs are working and anything of that sort.
Or even if you need something in terms of advice of how to reach out to a psychiatrist, a psychologist, I'm more than willing to help with that, and I know Rachel will be
same here. Any advice just for I'm in my 5th year of grad school, so if you're a grad student and just need to share, or again, I'm a yoga person, so if you're in the city and you have questions or even something you want to do at home, because sometimes yoga classes.
Even like
That's
beyond
really
yoga, like
and
I know
mindfulness techniques.
joining like the Philadelphia intramural like things, just being
Right.
around people,
Activities.
playing rugby like I
Yeah.
do.
Improv
Joining,
comedy.
Unless
I
you have
started
like
doing, that's
social
really
anxiety
helped me.
disorder, I would not recommend
Obviously,
playing rugby or doing that. But
I would
ultimately,
honestly-
I would actually recommend improv comedy if you have some social, because it's filled with friendly people and
but
it's
ultimately, I
just-
think that
finding hobbies is good, whatever it might be. I think finding a balanced life, because that's what also really helped me not feel out of control. And when everything feels out of control, when I said I'm going to give myself an hour for this, just knowing that I was doing that sort of maybe took that moment from a 10 intensity down a little bit.
All right. So that wraps it up for today's episode. We'll be back. Are you around next week?
yes,
Cool. We'll be.
I'm here. I'm back in the game.
Yeah. Oh, I love it. Season 2.5.
Yeah.
Rachel, you're more than welcome. You have our schedule. We're
Yeah.
going to do the innate immune system and its evolution next week, and then we're going to do the adaptive immune system and its further evolution.
Yeah.
And we're going to look at like different species. Like I really found it interesting about shark.
Shark
adaptive
immunology.
and
That sounds awesome. I think
really
I'm gonna have
cool.
to come back for that. And then I've also been doing some writing on cancer immunotherapy, which hopefully we'll get into once they've
Yep.
talked about the actual immune. I do love the immune system, so
So that's actually the show that's after that, cancer immunology
Yeah.
theories, therapies, and trials. So we'll talk about that. I'm actually really excited. In June 10th, antibiotic resistance, the crisis that we're going to be going through if we can't figure it out in the next 10
Yeah.
to 15 years.
So just to talk about that briefly, the FDA has actually created some pathways for some drug development associated with combating this issue because we're in such a deficit when it comes to producing these drugs. Some fast track approval therapies rather for stuff that is shown clinical significance in like phase 2A and stuff like that. So
All right, guys. Thank you for joining us.
yeah.
And,
Thanks so much for
we'll see
having
you
me.
back. See you next
Later,
week.
guys.
Bye. Oh.